Hello, welcome to Family Centered Care in the NICU, where we have been, where we are at, and where we are going. My name is Jody Heron-Bear, and I'm a clinical nurse specialist. I've worked in NICUs across the country in the states of Texas, Kentucky, and Indiana. I hope you enjoy the presentation today. In today's presentation, we will have 4 objectives. That is to define family-centered care in the NICU, describe the importance of family-centered care in the NICU, relate one nursing theory to family-centered care practices in the NICU, and identify facilitators and barriers to family-centered care in the NICU. So what really is family-centered care? It's a term that we use very loosely, sometimes in the NICU area, and we all need to have that same definition. So I want to start out with that idea of what really it is. And it really is a partnership between the family, patient, and our healthcare provider. So in the NICU setting, it really is between the partnership between our families and us as the healthcare providers or the nurses. And it really makes sure that we recognize that family is a very important component in the patient's life and their care, and we provide those opportunities for those families to be involved in that process. Because we know that the parents provide the emotional, developmental, and social support to a child, even in the NICU setting, and also to provide them some sort of control. As a parent, that's something that was supposed to be natural for them as they progress from being pregnant to having a child, and we take that away sometimes in the NICU, and we need to understand that. And we all know that this model of care is based in pediatrics across the country, and that we really need to embrace that whole idea of family-centered care partnering with our families. So where have we been? Well, we know prior to the 1930s, most babies were born at home, whether premature or term. That's just how it was. Babies weren't born in hospitals. And really, it was the early 1900s when the incubator was really first brought into the United States, and these premature babies were put on show. We know they were done in sideshows and in acts and things that were more for entertainment purposes than really for the use of from a hospital and a healthcare perspective. But during the 1930s through the 1970s, we transitioned really from home births to hospital births in this country. And really, it was really from the 40s through the 60s when we started that separation of mom and baby, and we thought it was actually better for everybody's health because of the sterility and making sure that people didn't get infected. By 1969, home births really had decreased to 1%, and that currently is really where they are still today. So again, where we have been is really from the 1970s to the 1990s. We started to understand that maybe parents needed to spend more time with these neonates, especially in the special care nurseries and the NICUs, as NICUs came on board with us really in the 60s, 70s, 80s, and 90s. So in the 90s, we really came back full circle and said, yes, parents need to be with these babies. It is better for them. And that's also when the Family Centered and Patient Care Institute was formed at the national level. And in 1993, Helen Harrison, advocate for family-centered care, really defined this concept for the NICU in particular. And as we move forward through the 2000s, what we have really been able to apply is really that understanding of what are our outcomes, really using a really strong research methodology and looking at the understanding the importance of the family and what that means for both babies and parents. We know that it can influence the neonate's growth. We know that it can influence parents' ability to cope. We know that parents have decreased stress. So that there's been lots of outcomes that have been put toward this idea of family-centered care and the importance of it. So the idea of family-centered care, especially in nursing, really falls under the family systems theory. And this was a theory that was developed by Dr. Murray Brown, a psychiatrist, and he believed that family is an emotional unit with very complex interactions and moving parts. And in these families, there's relationship patterns. And so when everything looks okay, there's really a balance in the family. But anytime there's an imbalance, there's increased tension, and that creates that imbalance. And one of those increased tensions can be an impairment of a child, i.e. a child in the NICU. So how does family systems theory apply to the NICU and nursing in relation to family-centered care? Well, what it what this theory, what it does is that it looks at the NICU and it shows that we have a loss of control, and we know that. That's nothing new to nurses who have been in the NICU for any length of time. We realize what we have to do to get the baby in the NICU and stabilized. Well, that creates that loss of parental control and that sense of what the parents thought that they would be doing when that baby was born. By being in a family-centered care environment and using the principles of family-centered care, we're able to increase parent presence, participation. The parents are able to be there physically, more emotionally, and that provides them that more control to be parents. And so by doing that, we look at Dr. Bowen's theory and we helped going back to that balance. We help create that balance back for them as much as we can in the sense of bringing that family into being a normal family. So when we say family-centered care, what do we really mean? And what are some of those ideas that come under this big idea of family-centered care? Well, some of them include, or they're listening to, respecting everybody in the family. That's something that we understand, but sometimes things get lost in translation, and we really need to really stop and listen. No matter how busy our day becomes, we do need to listen to families and respect them, no matter what their culture, their background, and we take that all in consideration. So again, talking about the cultural needs as well. So we just really need to be cognizant of that. So sharing unbiased information. We know there's a lot of bad news that comes in this area, and we need to be able to provide it in a way that so they can able to participate in the care. They feel like the parents are informed, and being very honest and truthful for them. This is hard, and we know that, and we need to prepare them for this because granted, we might or might not have been through it ourselves, but we've been through it with other parents, and we know this will be a rough road. So we need to be honest with them, provide them that information, and help them kind of process it as best they can. So we're there really to provide that formal and informal support. One of the studies that's out there talks about chatting by nurses, and that's that informal support. So when the parents come in, yes, they want to talk about their child, they want to get those updates, but they also want to feel like real people when they're there, because this is not a normal environment. So I think that informal support is really important that nurses provide in particular to these parents. So going on, we really need to collaborate with them. Again, that goes back to that idea of participation, having them present, being able to include them in this care environment. And again, we look at each family on its own and look at their strengths, look at their weaknesses, look at how they can provide the best care for what they are bringing to the table. So every family is not going to be the same. A teenage mom is not going to be the same as a mom and a father or a partner who has undergone in vitro fertilization and has had many attempts. So those two families will get the same information but delivered in a very different delivery mechanism. And so we need to, again, take that into consideration, look at the family strengths, and use that to the best of our ability. So what's the big deal? Why do we care about family-centered care? It's something we've talked about. It's something we use. We say it's nice, but actually it goes beyond nice. And that, as I said in the earlier slides, that we now know that there's better outcomes for these babies and for these parents, which again, that's why we all go to work every day, is to really provide the best care that we possibly can. So we do know from research that parents who've had a very family-centered care environment with all these principles put into place, that there's improved growth of the neonate. So, and as we know as NICU nurses, babies who grow faster, they get out sooner. So again, it goes to that decreased length of stay. And anytime we can get a baby out of the NICU sooner than what it was potentially kind of needed to be, then we've had a positive outcome in that area. So anytime we're out, that means that we're going to have less risk of infection and just kind of a cascading events down the line just because we're able to get the baby out sooner. The other thing is how it affects parents. You know, parents go through a lot, and we've learned this in the last few years about their psychological needs, and we really need to keep that under consideration. So really looking at parental distress from the acute standpoint of what they go through during that initial kind of NICU stay in that trauma-like environment, all the way through that post-traumatic stress. So, and we know that by providing family-centered care, it does decrease both the acute and post-traumatic stress for parents. So what is we as nurses can do to help promote family-centered care in our units, by our practice? So some of them, the big thing is that we enhance family involvement, and that can be our daily involvement and how we interact with families. And that's kind of what this whole presentation is really kind of getting at, is that, really involve that family from day one and every step of the way through this journey with them. And that starts with the NICU design and support space. And we know that not every unit can afford to build new units and make them as family friendly as we need to be, but as time has gone on in the last probably 10 to 15 years, we really have kind of moved from that open bay big unit concept where we have a chair maybe somewhere in the unit that's shared, to a unit that is a much more, has walls, has a door for a family, provides them maybe with a bed. So we know that that is helpful to parents. Through studies done mostly in Europe, they have shown that this helps decrease the family stress, that helps create more of a connection with this child. It really does help support the family. The next one is parent-to-parent support. And as long as we as nurses can't do this, particularly unless we were parents in the NICU, but we can kind of provide that system that helps them kind of find this. They need to find that person who's been through this as well, just because they don't want to feel like they're all alone, because we know they're not. Whether that be in person or online, there's many ways that parents can connect with each other, and usually someone who's been through this is more than willing and more than helpful to help support others who go through it as well. So that whether that be a support group through our units, or give the parents access to websites or groups that provide online support, that's something that we as nurses could help facilitate. And then the next one is technology, and as technology changes and it helps kind of support our idea of family-centered care, the use of webcams or FaceTime. Now we know that there's going to have to be policies put in place and help use with secure websites and things like that. So there are kind of things that need to be put into place before technology can be used, but it is one way that we can help promote family-centered care in our NICUs. And then in general, on our day-to-day interactions with parents and the children, is that we as nurses at the bedside really give that as opportunities to bond. And that's either through skin-to-skin care or holding, and then just doing basic newborn care, whether that be, doing a temperature or changing a diaper, or making it seem less like the NICU that a parent, again, going back to that parent control, we want to give them those opportunities for parents to feel like a parent to this child. So those are just some of the things that we can do as nurses. So kind of adding on from the last slide, really what nurses and parents, how we interact with each other, we need to make sure that we as nurses somewhat take the lead at first, and then as parents become much more comfortable in the NICU, we transition that care really over to them. So hopefully by the time discharge comes, that those parents are ready to walk out the door and feel very comfortable as a parent of this child. And so that's done through parent education. Whether the parent's there for 5 minutes or hours, we can provide some sort of education just as a reinforcement. We don't have to introduce everything new every day, but we do know that ongoing parent education is very important. Again, parent participation in decision making. Very, very important that they are given the information that they need in ways that they understand, so they can help, again, feel like parents to this child and really be involved. And that kind of also goes with that idea of being there on daily rounds. And so as we know, when our groups get together to talk about what's going on with this child, that parent be involved, so again, they can hear everything that's gone on with that child for the last 24 hours, and it really helps them feel like they are given the best information at the time that they need it. And then also making sure that family and friends are able to be present for the parents. We all have our different rules and regulations on what we've kind of come up with that works for each unit, but we need to be cognizant that sometimes that best support person for a parent might not be a grandparent. It might not be an aunt, or an uncle, or whoever they're related to. It might be a best friend. It might be, someone that they went to school with. It just doesn't. It might not be that traditional family model that we've all kind of looked to. So we need to kind of, keep the options open and kind of help parents understand that, who's going to be best for them during this journey with them. So going from facilitators to barriers in the NICU for family-centered care. So some of these are something that, a lot of things that nurses, we can't do anything about, but some of them we can. So we just need to be cognizant of these. So one of the big things is having no overnight accommodations for parents. And that's been shown again in the research that if they have abilities to stay with the baby and have kind of a space for their own, that they feel more present, they feel they participate more, and we're able to provide better family-centered care for them. And that kind of goes that idea of a non-family friendly environment. So if we don't have a space for them, if we have rules of you can come in at this time and you have to be gone by this time and you have to do this or you do that, that starts to kind of feel like that they're not welcome. And so again, we need to provide a safe space for these parents, and the visitors of the babies, but we also need to make sure that the families do feel like that this is their child. Then again, also that kind of plays into that whole idea of uniculture and the idea of, how open are we about having family there, and some just in general, some comments, and that's where nurses we need to be understanding of parents and making sure that we use the language that is correct and more family friendly. And so we need to provide those opportunities for families to do skin to skin care and, participate in care. And again, it goes a lot to the nurse's comfort level, but again, that just gets built through culture and how nurses kind of help teach new nurses on how that evolves in their care. So, and then again, just one of the biggest barriers is and like anything in healthcare, it's ineffective communication. So just not either communicating with parents using words that we think of as just normal language, but as we know in the NICU, we have a whole new language of our own with letters and what do all these mean to parents? So we really need to, again, step back and really listen to parents and give them the information, but then to kind of judge their look and kind of what they can tell us back, and to see what we need to kind of enhance and kind of go through again so they truly understand what's gone on with their baby. So as you can imagine, just by being in the NICU, we also know that there's barriers out of the hospital that, again, as nurses, we have no control over, but again, we need to be understanding of parents that they are going to fight and have some things that have to go on outside of the hospital that will be a barrier. One of the big ones is siblings at home, and if we as units don't provide sibling care or some place that siblings can be while the parent is in the NICU, that's going to be a barrier to them, because most people have younger children and have no one to watch them. So we need to keep that an idea in our heads. So the other one is just basic transportation to the hospital. We know a lot of parents, either in the city or in the rural area, they might travel quite a bit of ways to come to this NICU. And so we just need to keep that again back in our heads of understanding that transportation, that's something that we might take for granted in our daily lives, that just might be a struggle for wherever they are in their world. And that kind of goes next to that idea of economic reasons and so on. And so making sure that, again, we don't need to know all pieces of a family's life, but again, making sure that we don't pass judgment on these families on if they do struggle economically, whether that be for a variety of reasons, but we just need to make sure that we understand and to keep that back in our heads when we're talking to them and when we're trying to plan care for this child. So one thing that you as a unit can do, you can go on to the National Perinatal Association website and download this self-assessment checklist tool. And it talks about comprehensive family support, but it really encompasses family-centered care in general. And so I just kind of gave you the first page of it, but and I gave you in the websites here, and it'll be listed in the references. But it's just a good tool that as a unit you can do, or as a shared governance council you can do, or just as an individual nurse. You can kind of go down the list and say, where do we stand with these ideas? And so so I think it's a good tool to use just as setting goals for a unit. So I just wanted to kind of bring that up to everyone to show that it's out there, and I think it does a nice job and encompasses a lot of things. And to be quite honest, most units won't be able to cover everything in this checklist. But again, it's one place where as units and as nurses we can go and kind of look to see what are some of all the things that we should be doing. So where are we going? So we need to be able to take our ideas and we need to check ourselves in our everyday practice, and that's what we individually can do. So set goals for yourself when you come into your unit and say, what am I going to do to promote family-centered care for my families today? Next one is you can help eliminate barriers in your unit. You can discuss those with your shared governance councils, your leaders, your charge nurses, whoever those might be in your unit, that you can talk about, that we know that these barriers sometimes exist and what can we do about those in-hospital barriers. And the next one is really to share that checklist with coworkers. Again, going back to your shared governance councils, your leaders, what are some things that you might be able to? Obviously, you wouldn't be able to do the whole checklist in a year, but really to focus on just a few things and really kind of hardwire those ideas for your unit to make sure that families get the best family-centered care. So here are my references that you guys can check if you guys want some more information regarding family-centered care and about some of the ideas that I brought to you today. So I hope you enjoyed the presentation, and I hope you enjoy the readings that are also provided in this module. Thanks so much. Bye-bye. So here are my references that you guys can check if you guys want some more information regarding family-centered care and about some of the ideas that I brought to you today. So I hope you enjoyed the presentation, and I hope you enjoy the readings that are also provided in this module. Thanks so much. Bye-bye.